Well, good evening. Thank you all for joining us. This is the uh, webinar on new technology for occipital cervical fixation, presented to you by the Cervical Spine Research Society. I'm very pleased to co-moderate this with Dr. John Heller. A couple reminders. We do have the 52nd annual meeting of the CSRS coming up this December in Chicago. Abstracts are currently being accepted for another few weeks until April 24th. So we encourage everyone, if you have any research to submit, we would love to see it at the 52nd annual meeting. We also want to remind people that the Clinical Spine Surgery Journal is the official journal of the Cervical Spine Research Society. We'd encourage you to submit any papers focused on cervical spine to the Cervical Spine Surgery for possible inclusion in the upcoming issues. We're also, with the CSRS, becoming involved with social media, so we encourage you to follow us on the various formats, whether it's in LinkedIn, Instagram, X, or Facebook, and those are all the various identifications of CSRS on those societies. So please give us a follow so we can keep you up to date on any other upcoming events with CSRS. And then, as I mentioned, CSRS has a YouTube channel. This is a repository of presentations put on either at CSRS, the instructional course, or webinars like this. There's a growing amount of information there, so please give it a look and subscribe to the CSRS YouTube channel. So tonight, this is just our agenda for the evening. So Dr. Heller and I will lead off. Then we'll have Dr. Heller will do a review on anatomy. I will talk about how I do it for occipital cervical using both freehand and Fluoro-assisted. And then we're really pleased to have Ilyas Aleem from University of Michigan to talk about how he does it with navigation assistance. And we're especially proud to have Dr. Nick Theodore from Johns Hopkins, one of the fathers of robotic spine surgery, give us his take on how he does it using robot assistance. And then we'll finish up with some case presentations. We have one from Dr. Heller, and if time permits, I have one as well. And we'll all the panelists will be there for a live discussion.
Good evening, everybody. My name is Ilyas Aleem from the University of Michigan. I'd like to begin by thanking the CSRS, the Cervical Spine Research Society, as well as Dr. Wright and Dr. Heller for this opportunity. So I'm going to be talking about the how and why I do it, navigation-assisted technology in cervical spine surgery. I do have some disclosures here, so some research funding from Orthofix and Nuvasive, as well as a consulting relationship with Globus on some of their navigation-assisted technologies. The reality is that lifelong learning is a very real thing in spine surgery. Although I trained in residency without using any navigation or just kind of dabbling in it really, and then during my fellowship at the Mayo Clinic, we started using more navigation with some of the attendings that we worked with. At the current time, I mean, I use navigation pretty much for all upper cervical spine surgery cases. That's really been a change for me with regards to my practice pattern. But spine surgery is always changing. And I think that there's numerous advantages to navigation-assisted technology that I'd like to discuss today. And on that note, several years ago, I had the opportunity, just a plug for the CSRS Traveling Fellowship here. So I had the opportunity to participate in this traveling fellowship where we traveled, across East and Central Asia, essentially learning techniques in spine surgery. And one of the biggest or most eye-opening things for me participating in this was that you realize how much new technology is not only being utilized but also developed in this part of the world. For example, when we were in Japan, I was surprised to see not only CT navigated instrumentation, but also some virtual reality assisted surgery with these virtual reality headsets that we had the opportunity to try to use. And you can see here the virtual onlay of anatomy sort of while you're operating on a patient's spine. And so, so really, I think that the times are changing. Initially, with any new technology, the benefits are debatable. I mean, early stages of GPS navigation systems, you can see that they're fairly bulky, even ugly, some may call it. Everybody knows how to get from home to work to the grocery store. So, what's the point of using this? But you can see over the years, how these things change and not only, just look better, but also become a lot more streamlined, a lot more efficient, and start providing information that otherwise wouldn't have been possible. So this is your typical Ann Arbor grid in the summertime. And you can see, various construction blocks. And so there's continuous rerouting that happens. I'm not sure if winter is much better. So actually reading that Michigan is probably one of the worst places for winter driving. So again, helpful in that regards. Then there's always things happening. So, there's various events, fairs, there's road closures, there's sort of live updates. And so although you might kind of know the path to get somewhere, your GPS system is doing a lot more than just providing directions. And so really, providing real-time alerts for traffic, police, accidents, and more. And now with automated driving, this is evolving even further. And so, as far as cervical spine surgery, the relationship between the cervical vertebra and surrounding neurovascular structures creates inherent surgical challenges in cervical spine surgery. Regardless of how many cases we do, there's always cases of patients with unique anatomy, unique considerations, and placing or performing surgery safely is always a challenge with regards to fixation, decompression, whatnot. And so accurate placement of spinal implants is really critical to avoiding complications. When you look at stereotactic navigation, which has been around for some time now, essentially uses CT or pulsed fluoro obtained preoperatively or intraoperatively and image processing software to generate a volumetric model of the patient's anatomy. And numerous advantages have been shown with this technology. I mean, it improves accuracy of screw insertion, decreased rates of returning to the operating room. When I was in my training in medical school and in residency, I remember coming back, having to come back to the OR for a screw that was placed, too medially or inferiorly, through the foramen, and the patient, still has some symptoms, and you're always thinking, hey, was it the screw that you need to redirect? And we would come back to the operating room to redirect screws intermittently. Less radiation exposure for OR teams and the patient, so now we essentially do our initial localization spin or localization X-ray, and then we don't need lead anymore. So the rest of the case is all done without lead. Improve resident in education and involvement, as well as OR staff engagement. So, I think that there's some intangible benefits here as well. When people in the team can see what's going on and they're engaged, they can anticipate steps, prepare the instrumentation and whatnot, and anticipate what's going to happen next and be ready for you. And then resident education. I mean, it's very easy and very comfortable to see what the resident is doing, what's going on, and these are all sort of inherent benefits of navigation. So, kind of coming down to specifically how I do it with regards to posterior cervical surgery. So we use the Allen frame as shown here. I use Mayfield tongs on all patients. Important to remember that no technology replaces preoperative planning, right? So every case is still getting its full preoperative planning. We book the case in advance, so no one likes to run around looking for an O-arm that wasn't booked. We want to plan all screws and trajectories. So this is all done in the preoperative planning stage. I do get a preoperative CT on everybody. And so we use a Mayfield. We use a reference frame on the back of the Mayfield that's draped in. I'll show you some pictures of that. And then cranial fiducial screws. So I found this is really helpful with regards to looking at accuracy. So one of the criticisms of this is that there's a lot of mobility in the cervical spine, and as you're placing instrumentation, or if there's any instability or things, that you might lose accuracy. And so that's something that you need to be aware of in real time with regards to how accurate your system is, and that's why we use these cranial fiducial screws. And so this is an example of the setup here. So, standard kind of Mayfield, opposite to the Mayfield. Place the stealth arm here, and then the patient is draped, and then we use the sterile reference frame here. And you can see that, this is cranial here, so it's completely out of the way, so we're not putting a spinous process clamp on, anywhere in the field. And the benefit of the cervical spine is that, things are relatively smaller and close together. And so you really don't lose any accuracy, or I'd say minimal accuracy, with regards to placing instrumentation all the way from occiput down to upper thoracic. And so, our O-arm is brought in here, and this is just what we use, the Medtronic O-arm, but, any of the systems are all very similar. And then the spin is performed. And so from the time that the O-arm, and again, we call the O-arm in advance while we're still exposing. So from the time of calling it in to scrubbing back in, we're looking at about 5 minutes. So really not taking a huge amount of time away from the case. This is an example of the fiducial screws. So I placed a few of these fiducial screws kind of throughout the field, very small 1.5 millimeter cranial screws. And so when I'm operating, we can tell exactly with our reference frame where, how accurate we are. And if there's any shift in the accuracy or any change, then that's something that needs to be known to the surgeon, and we can tell in this way exactly by quantifying it. So you can see here an example. Very easy to see exactly where your screw is going to go. You can imagine, if a resident or a trainee was pointing out where they want to put the screws in terms of anatomic learning and whatnot. This is a patient with a Klippel-Feil. And so very easy to see after we kind of determine where we want to put the screw. Similar technique of just using a small burr, creating an entry point, and then a drill. And again, we can see exactly where that's going, and then placement of the screw. And so I wanted to put this slide because, again, sometimes people look at this and say, oh, look, your navigation is completely off. Well, yeah, when you're placing the screw, I mean, there's some movement of the spine. And so you can see that, it might look like it's a little bit off. But again, this is not, just placed without any other checks. We're kind of, all senses on, using anatomy, using our frame, using the previous checks. We use a ball tip, and so we know exactly where this is going. So this doesn't really concern me, because understandably there's some motion here when you're putting this in. This is another example of a placement of a C1 screw. So I think Dr. Wright did an excellent job of describing sort of where these screws go. I tend to use a little bit more of a medial start point for C1, and then kind of using a straight in trajectory. And you can see that here, and this is a patient with C1, C2 fracture that we stabilize with C1, C2 arthrodesis. And so not only is navigation used for posterior approaches, I do use it on occasion for anterior approaches. So specifically in cases of OPLL or severe OPLL when I'm going in anteriorly, or cases of odontoid fracture, and I'll show that here as well. So this is a 43-year-old lady with severe myelopathy. I'm not sure how well this is coming out here, but basically you can see that she has sort of this development of OPLL, sort of this heterogeneous calcified kind of mass here, just behind her vertebral bodies. And you can see that there. And so the benefit of using navigation, and so here, and this is our setup. So a similar setup, so Mayfield, stealth frame attached here. So again, completely out of the way. And you can go about with the exposure and the rest of the case sort of exactly as you normally would. There's no, spinous process clamp or anything like that. And so the benefit here, as you can see, is that you know, and I'm not sure how well this is coming off here, but you can really assess the width of your corpectomy here to ensure that you're going to be sort of completely around the ossified fragment or ossified segment, sorry. And so that's both superiorly, inferiorly, and then as well as medial lateral. And so this is helpful because you can determine exactly or be confident that you've essentially removed the entire ossified segment. And so that's an example. That's an example there. This is a 64-year-old patient that fell from a ladder. I can see she's got sort of this displaced odontoid fracture, some C1, C2 subluxation here. And so this is another example of a patient that we set up with the frame here, you know, use the O-arm, you know, did our reduction. We were able to evaluate the reduction with the O-arm. And then, you know, essentially use navigation. This is obviously fluoro here, but in this situation, we're able to use navigation and then double check with fluoro, knowing that this is an unstable situation where, you know, there could be some shift of the fracture as well. And importantly, you know, I wanted to point out that once our instrumentation is in, you can actually get another spin and ensure that you've got an adequate fracture, you know, adequate fracture reduction and placement of instrumentation. So you're confident when you leave the OR that everything is, you know, sort of exactly where you want it to be. And there are some post-operative films of this patient with this partially threaded lag screw. So, you know, in summary, you know, obviously, you know, we don't suggest, you know, just using navigation and blindly following it, you know, or else you end up sort of like this guy here. You know, navigation does not replace key knowledge of anatomy and preoperative planning. It's best used as a guide to support the surgeon, and it does provide additional information, increases safety and educational value that's otherwise not available. And I think that's a very important consideration here with regards to educating residents, fellows, and as well just engagement of the operating operating room team. And then, of course, it should never be solely relied on without confirmation from anatomic landmarks, as this can obviously cause harm to the patient. You know, and I will say that, you know, of the numerous, you know, hundreds of cases that we do now with navigation, you know, fortunately, I've never had to come back to redirect a screw, or I've never been surprised with the post-operative scan, you know, about the screw placement. We can very safely place, you know, C2 pedicle screws very comfortably and get really good fixation. And we have, you know, our team has described the technique that we use for computer-assisted navigation and anterior cervical spine surgery as well. And so there's some references here. So thank you very much for your time, and I look forward to further discussion.
Well, I thought this was an amazing webinar. I really appreciate the working with John, and I really appreciate the input from Dr. Theodore from Johns Hopkins and Dr. Aleem from University of Michigan, looking at these new technologies. I think they are bringing extra tools to the field and making our surgeries better. So, John, unless you have anything different, I'd just like to thank everyone for participation and a wonderful webinar.
Yeah, thanks. It's like we had a good crowd, and hopefully everybody enjoyed it.
Yeah, thank you for putting together,
And
Neill.
Maria, thank you for cobbling all this together. Close it out. Have a good night, everyone.
Thanks.
Yeah, thank you, everybody.